We're excited today to have the USU's Counseling Center team talk to us about eating disorders and disordered eating in the military. I'll get started by doing brief introductions of our speakers, and then I'll hand it over to them to continue the presentation. So first off, we have Colonel Nathan Keller, who is the director of the USU's Student Counseling Center. Dr. Keller has a PhD in social work from the University of Texas at Arlington and Masters of Social Work from the University of Georgia. He has been practicing social work as an active duty U.S. Army social work officer since 1994. And then we have retired Colonel Dr. Schneider, who is the medical director of the USU's Student Counseling Center. Dr. Schneider received his medical degree from the Creighton University School of Medicine and did general psychiatry and then child and adolescent psychiatry fellowship at Walter Reed Army Medical Center at the time. He was previously chair of the Department of Psychiatry at the Walter Reed National Military Medical Center and was also vice chair of the Department of Psychiatry at USUS. And we have Dr. Nakia Clark, who is a clinical social worker at the USUS Counseling Center as well. She's licensed certified social worker, nationally certified financial social worker, and Department of Transportation, the Association of Addiction Professional, Qualified Substance Abuse Professional as well. She has a doctorate degree in metaphysics from the Metaphysics Board Certified Annual Practice School of Metaphysics with focus on holistic approach to evidence-based therapy, as well as Master of Social Work degree from with concentration in public health from Morgan State University. Dr. Clark is a retired U.S. Navy Hospital Corpsman, first class petty officer, and she served honorably on active duty from 2001 to 2021. I sent out the bios of our speakers, so please take a look at them for more details. With that, if you have questions as we go forward in presentation, you can put it in the chat and I'll be monitoring the chat, or you can wait until the end of the presentation to ask your question as well. And also, please don't forget to complete a session evaluation and survey for ground rounds that I sent out in the email, but I'll also put the links in the chat box as we go forward with presentation. With that, I'll hand it over to Colonel Keller and our speakers. Thank you.
Good afternoon, everyone. It is our pleasure to spend a little bit of time with you to talk about eating disorders and disordered eating, specifically within the military population.
Hello.
It is our goal today to give you kind of a general overview of what eating disorders are, particularly the most common ones that you may come across in working with the military population. We'll give you some ways to kind of identify and assess the process of diagnosing eating disorders and understanding how to manage them. And when it comes to managing them, we're going to try to concentrate on the medical provider's role within the management. We think that might be most beneficial to this particular audience. Then finally, we're going to share some TRICARE approved resources within the local area for managing eating disorders. So we'll share some resources that we can refer our patients to in network, as well as discuss some resources that are out of network. It's always a good place to start to kind of define what it is that we're actually going to be talking about, right? And so when you think about eating disorders, essentially there are this kind of behaviors and conditions characterized by a maladaptive relationship with food. Typically, in order for us to survive, when we think about that Maslow's pyramid, food and shelter is at the lowest of that pyramid, right? And so individuals that have trouble, even with those basic needs and foundations, is there's a psychological disconnect between meeting that need and how they perceive themselves. And it causes a significant dysfunction in social situations and professional situations, and their ability to maintain positive functioning throughout their lives. This condition is non-discriminatory, right? So it's found in any age group, as young as 2 and 3, all the way up to our geriatric population, regardless of gender and regardless of cultural affiliation. We want to kind of focus on, well, how does that eating disorder affect our military culture, and what role does the military potentially play in influencing those eating disorders? The military has a long-standing tradition of physical fitness and how individuals look in their uniform. Being your best self, your most physical healthy, is crucial in allowing all of our service members to accomplish their missions. Coming into service is a very physically demanding and challenging opportunity in order for us to achieve success. So there's lots of emphasis placed on how you look and what your body can do. You would think that this would be a good thing, right? And so we try to surround our service members with positive images and reinforcements that promotes healthy diet, exercise, and taking care of yourself. But what we found is there is a negative piece to that culture that does influence potential eating disorders for our service members. If individuals are struggling to meet weight or struggling to stay physically fit, there are both quantitative and qualitative consequences to not being able to perform those parts of your duty. The negative consequence that is kind of quantitatively measured is flags for promotions and awards and schooling opportunities, flags for sometimes going to schools and training, and even taking leave to a certain extent. And so that reinforces, if you are not able to eat and diet and maintain weight and physical fitness standards, then you are a substandard service member. Qualitatively, there's an underlying non-official negative perception of service members who are unable to meet these standards. And they are often ostracized, made fun of, given the lowest level duties, and kind of made to feel that they don't really fit within that cohesive unit. For officers, it is often reinforced that the best impression that you can make when entering a unit as a leader is what you can do physically, right? Because that is a visual representation of your ability to meet that standard, how you look in your uniform, how you perform within those PT formations. And so a lot of our credibility as leaders and followers within our services comes from how we look and our ability to perform some of these physical acts. These are just some empirical evidence that kind of substantiates that type of stigma. This often leads to disordered and eating disorders that are actually diagnosable, right? And so as we think about these stigmas and as we think about some of this negative reinforcement, it creates a negative psychological relationship to the intake of food, right? We're no longer seeing it as something pleasurable, as something that we need to energize our bodies. We see it as an obstacle that allows us to achieve successes within services. That's also true for our military families, right? So there's been lots of studies that have been done with our dependents, and they are considered to be high risk because the data kind of indicates that our family members are trying to control their environment through food. And if you're always moving, relocating, changing support groups, one thing that you absolutely have control over is the way that you eat. And so that's coming up as one of the significant variables that's contributing to higher rates of eating disorders within our military families. So what are some of the common eating disorders found within the military? There are 4 that are primary. We're going to speak to anorexia, bulimia, and binge eating in more detail. But the other one is the eating disorder NOS, right? And when you think about this particular disorder, it is specific to achieving a military objective of meeting the height weight standard. And so for these, we see service members that are avoiding food or participating in some of these fad or very extreme diets or restricting their food intake with the goal of passing that particular standard. Once that standard is achieved, a lot of times they kind of go back to more normal eating, but they find themselves getting in a pattern of exercising this negative relationship with food around height and weight weigh-ins and PT objectives. The other ones lead to often more significant consequences. And so in order for us to be effective, there is no one particular specialty that is going to be successful in managing one's relationship with food, right? Because food is necessary, it's not something that we could stop doing, but it's something that we have to kind of figure out how we can do in a more healthy way. And so it touches all areas of our lives. So you're going to have a behavioral health component that kind of takes a look at that psychological and emotional relationship, but you're also going to have a physiological component, because these types of patterns and maladaptive behaviors wreak havoc on multiple systems within that body. And in order for us to treat it, we have to pay attention to how malnutrition is going to degrade a person's ability to be physiologically sound. And then there's nutrition, right? And so it's what should we be putting in our bodies when, and how can we help develop patterns around healthy eating? And so our dietitians and our nutritionists are also going to be extremely important in establishing these healthy relationships. So when we think about that multidisciplinary team, we're going to be talking across various treatment platforms. So obtaining releases of information and ensuring that the client is aware and the patient is aware and comfortable with this type of crosstalk behavior, right? Because we're going to have to be able to share notes and kind of approach it from our own specialties in a unified way in order for us to achieve success. The other thing that's super important is ensuring that that patient and client have support themselves. So an individual relationship with the providers, even a multidisciplinary team, is often not enough. We also have to include their support systems that come from their lives. And so we're talking parents for children, caretakers, spouses, chain of command, battle buddy. All of those folks are going to be crucial in aligning a way to reprogram their negative relationship with food. So now we're going to kind of talk about the medical provider's role, and Dr. Brett Schneider is going to walk us through what a medical provider or a primary care provider as part or role in this multidisciplinary team looks like. Brett?
Thanks. Can you hear me okay? Can you hear me okay, Nate?
Yep.
All right, great. So good afternoon, everybody. Thanks for giving me the opportunity to share some information with you. The first thing you want to think about is if you have somebody come in, you have to have some clinical suspicion that somebody has an eating disorder. Might not always be clear to you. And one of the things that we would hope as the general medical clinician that you would rule out other causes of weight loss, vomiting, menstrual irregularity, those kinds of things that might be comorbid or underlying problems as a result of the eating disorder. So consider those kinds of things. We also think that one of the main ways that our primary care colleagues can be helpful is by helping to assess for the medical complications and helping to monitor those issues. In the acute stage, that would be things like vital sign stability, electrolyte abnormalities, hydration status. In the longer term, that would be things like bone density, menstruation, and growth issues in even younger patients. For patients specifically with anorexia, it's often necessary to check their height, weight, and vital signs on a consistent, even weekly basis to ensure that they're having the weight gain and that they're maintaining medical stability, especially when they're on the outpatient basis. Next slide, please. One of the things about working with the patients who have eating disorders is that by definition, they're often secretive disorders, and the patients aren't always so interested in trusting people with what's going on with them. You won't automatically be seen as an ally, even if they initiate the appointment. So the typical doctor-patient relationship of patient has problem, comes in, asks doctor for expertise to help. That's not always automatically there in these situations, and there'll have to be a little bit of prodding to figure out what's going on. There's a paradox of not wanting to give up the eating disorder and not wanting to work with someone and they often want to fool people. I actually have a patient with anorexia that is a big part of what we are working on, actually, is that desire to kind of get over on the treatment team and things like that. So that is definitely a real thing that happens frequently. They want to know that you're on their side while still challenging their eating disordered thoughts and behaviors. You cannot work on weight loss and recovery from an eating disorder at the same time. You have to kind of work on one first and then get into the recovery, or weight gain if it's anorexia. And the eating disorder often is seen as a separate entity from the person. A lot of the eating disorder patients that I work with actually talk about it as if it was a thing of its own, separated from them. Often that's a part of what they do that because they actually do feel shame about it, but also have a hard time giving it up. Next slide, please. Let's talk specifically about anorexia nervosa. Next slide. What in the DSM-5, it's a restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of your age, sex, developmental history, and physical health. It used to be in the DSM-4 that it had like a 80%, of BMI or something, but they got rid of that and just said that it's a significantly low body weight now. They also have intense fear of gaining weight or becoming fat, even though they're already underweight. And there's a disturbance in the way in which one's body weight or shape is experienced. For example, that one patient I was talking about, one of their triggers for activating their disordered eating is if they feel certain parts of their body as touching clothes a certain kind of way, or feeling like a disgusting fat body, they call themselves, or whatever. And it makes them feel out of control when they see those kinds of things. And then activating the eating disorder actually helps them to feel more in control again. Next slide, please. Here's some signs and symptoms of anorexia. Obviously, low body mass index is the main thing. And because of that, they can look emaciated. They can have bradycardia, hypertension, dry, scaly skin, brittle hair. They get some of the lanugal hair that you can see. Symptoms, they can have amenorrhea. That's a common one if they're have the low body mass index. They might have palpitations, dizziness, bloating, and constipation. Next slide, please. Now here's some to help with the medical workup. Here's some kind of if you're ever going to hospitalize or send somebody someplace, this is probably the list of labs you should probably obtain prior to getting them approved to go someplace. So, and also just to make sure that they're medically stable and safe. So electrolytes, BUN, creatinine, glucose, calcium, albumin, prealbumin, INR, CBC, LFTs, thyroid, vitamin D, and a pregnancy test in females or testosterone test in males. Next slide, please. I'm not going to go through every one of these, but this is just kind of the different ways that having anorexia can end up affecting your body. Again, probably the hormones is a big one. The heart is a big one, especially in the acute phase. And then the other ones, just go ahead and look through them and just be aware that pretty much any system in the body can be affected by a severe case of anorexia nervosa. Next slide, please. So to do some clinical management, the first thing that you have to, well, there's 4 places you have to have your focus. One is if they're extremely low weight, you have to restore their weight. You have to monitor their medical complications. Those would be two areas that we may have, our primary care doc friends working with us on specifically. Then you also have to modify their disordered eating behavior and address the psychological and family issues that they have. So the treatment methods typically include nutritional rehab, that's the dietitians, so they're consults for them, psychotherapy, so if you're the first people to see them, referral to behavioral health as well, and then medication. There aren't a lot of pharmacotherapy options specifically for anorexia nervosa because restoring weight is a big thing. One thing that has been used with some success is olanzapine. I often tell people that I have never put a patient on olanzapine who didn't gain weight on it. If they're not gaining weight on olanzapine, they're not taking it. I can almost guarantee you that. So even just 5 or 10 milligrams of olanzapine will cause weight gain in people. A lot of these people have distorted thoughts about their body image, which we talked about, and food generally, but that does, unlike OCD or paranoia of psychosis, that is typically not something that responds very well to medication treatment. So a high dose of an SSRI and or a typical antipsychotic are often not that helpful actually for that particular symptom that people may have that's a primary symptom of their anorexia. The other thing to think about is that there's lots of comorbidities with anorexia nervosa, depression, anxiety, etc., that treating the underlying condition then with an SSRI or another medication may be indicated and is necessary usually to get them back into a more normal state. Next slide, please. Now we're moving over into bulimia. Nice picture there, Colonel Keller. What is bulimia? It's recurrent episodes of binge eating. And an episode of binge eating is characterized by both of the following: eating in a discrete period of time an amount of food that is definitely larger than most people would eat during a similar period of time, and a sense of lack of control over eating during the episode. Then you have the second part is recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting, use of laxatives, diuretics, or other medications, or fasting or excessive exercise. A lot of those behaviors can also happen in anorexia. Also, the binge eating and inappropriate compensatory behaviors both occur on average at least once a week for at least 3 months. And then their self-evaluation is often influenced by their body shape and weight as well. But theirs is often, they're usually bigger than the anorexics. That's one of the distinctions between them, is that they're often overweight and are trying to manage this. And the disturbance does not occur exclusively during episodes of anorexia, obviously. Next slide, please. So here's some signs and symptoms of bulimia. As you can see, some of them are similar under the signs of menses and lethargy, pain, abdominal pain and bloating and constipation. It's more likely, of the 3 that we were talking about today, the bulimics are, believe it or not, the ones who are more likely to be involved in non-suicidal self-injury and cutting and picking and burning of themselves and stuff like that, more so than the anorexic nervosa patients are. So if you have somebody who, that might be one thing to think about in your cutting patients. If they're overweight and they have any fluctuations frequently in their weight when they present to the clinic, it may be a good thing to ask them some questions about bulimia. They also can have, one of the big things that they can have is if you look under symptoms, the second to the last, the scarring or calluses on the dorsum of the hand, which build up over time from them if they're the vomiting type of, if that's their compensatory behavior, is vomiting frequently. Next slide, please. Laboratory assessment, fairly similar to the anorexia, although we add in the laxative abuse can be assessed by checking stool or urine for some different substances. And also, if you suspect pancreatitis, check the serum amylase or fractionated for saliva gland isoenzyme for that. Next slide, please. And here's how bulimia affects your body. Again, one of the main things to notice is that it can affect most areas of the body, most systems. Again, throat and esophagus is probably a little bit more than an anorexia because of irritated throat or ruptures or tears and things from vomiting. That's a big one usually. But they also have they can have irregular bowel movements with the laxatives and things, and cramping if they're using those sorts of things. And also their hormones often cause them to have irregular periods as well. Next slide, please. So again, managing bulimia, you want to help them to modify their disordered eating. You might have to have them be observed after meals to avoid vomiting. You want to help them maintain a steady weight at a good, healthy amount. This one actually does have some pharmacotherapy. If you want to think of a medication, think of Prozac, fluoxetine. There actually are about 4 different studies that show if you try to titrate it up to 60 milligrams, that can specifically decrease the binging and purging behavior in these patients. It's recommended in those studies not to use Paxil because of its more significant risk of weight gain, or citalopram because it has the underlying cardio problems that people can have with that. Another medication you might think of in this group is topiramate for weight loss. I actually have a patient with bulimia who we were going to try that in here recently. And let's see, and this one also has a lot of comorbid psychopathology, so treating the underlying disorders is an important part of this as well. Depression, anxiety, OCD being the top comorbid diagnoses in this group of people. Next slide, please. And then binge eating disorder. Next slide. Binge eating disorder is characterized by recurrent and persistent episodes of binge eating. Binge eating episodes are associated with 3 or more of the following: eating much more rapidly than normal, eating until uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of embarrassment by how much one is eating. Then usually after they eat that huge amount, they feel disgusted and depressed or guilty about it. And they have a lot of problems with, sharing that they're binge eating and stuff. And they don't have the compensatory behaviors though, such as the purging. That's a big part of what makes it different than bulimia. I actually had a patient, active duty guy, who his binges would consist of going to like a drive-through for McDonald's, and he would literally get like 7 combo meals, 6 milkshakes, 5 apple pies, and then like maybe some other thing or 2 on the side, and would just devour all of those things all at once and then feel horrible literally as soon as he finished doing it. We ended up having to have his wife monitor his credit cards or take them away from him, only give him like $5 to go to work so that we could help him to stay away and manage that while we were trying to treat it. Next slide, please. Some of the things for you guys to keep track of, the medical status. I mean, obviously, if you're eating 7 McDonald's meals, you're probably going to have some obesity going on. So checking BMI, checking their waist circumference. They're more likely to have hypertension, diabetes, GERD, sleep apnea, joint pain, all those kinds of things. Get a nutritional status on these patients. Ask about a lifelong weight history. See what their current patterns of eating are. What their bingings consist of, the what, where, how often, intensity. Do they eat at night? I actually have one patient who that was a big part of it. And, that one of the meds when we get down that is indicated for it, has FDA approval, is actually Vyvanse. Well, you're not going to give somebody Vyvanses that are eating in the middle of the night though. So that kind of limits your ability to be able to help with that. So there are psychotherapies for it: CBT, dialectical behavioral therapy, interpersonal therapy, and then pharmacotherapy. It suggests trying to do a course of an SSRI. Again, I would probably use Prozac, 60 milligrams for that, although there weren't specific studies that said that like there were for the bulimia, but it makes sense because it's the same behavior that you're shooting after. You can use topiramate again, for weight loss, and as I said, Vyvanse or lisdexamfetamine has an FDA approval for that disorder. And there's a form on the military formulary that you have to fill out to get that for people. Next slide, please. Different levels of care you might have to think about. I mean, there's obviously just regular outpatient, but there's also intensive outpatient, partial hospital programs, and residential treatment, and also inpatient, which I'll talk about in a minute. So IOP or regular outpatient treatment, your patient needs to be medically stable. So again, all the things that we talked about evaluating for that, and would not need daily medical monitoring or that level of medical stability. They're also psychiatrically stable, and as their symptoms are under sufficient control that they can function in normal social situations and continue to make progress in recovery. So this person is probably able to go to work. You know, they're just coming in once a week. You know, often, like my one patient who is working has a therapy appointment and 1 or 2 groups and the dietitian. So they're still, you know, technically that's almost IOP right there with 4 hours a week of some kind of therapy. In the partial hospital, that takes it up to the next level. Again, they need to be medically stable, but their eating disorder, impaired function, don't have immediate risk though, but it's a little bit higher level of dysfunction with that. They're heading in the wrong direction, for example. They'll need daily assessment of their physiologic and mental status. They're psychiatrically stable, but they're unable to function in a normal situation, and they're engaging in daily behaviors that are affecting their relationship with their food. So you would want to try to help them get that under control. So that might be a partial hospital person. And then residential, that's sending someone away for an extended period of time. They would again need to be medically stable and require no intensive medical intervention, because that's not what they do at residentials, but they're psychiatrically impaired and unable to respond to partial or outpatient treatment to the point that they need a more controlled environment over a longer period of time. And they would have demonstrated having lack of success in these other levels of care to justify going to residential treatment. Next slide, please. So when to hospitalize, if you got somebody who comes in and you're checking this medical stability we keep talking about, here are some things that would suggest that they need to get hospitalized. If they have unstable vital signs, blood pressure less than 45, let's see, and less than 20, let's see, yes, or they would have electrolyte abnormality, cardiac disturbance, syncope, the low body weight. Here it says less than 75% of their BMI, failure of outpatient treatment, and it's also indicated if there's a risk of suicide, if there's psychosis present, or if there's a major lack of motivation towards resolving the eating disorder. Next slide, please. And then inpatient, if they're, you know, that they would need inpatient if they're not stable. The inpatient team's goal for admission is medical stabilization. They would do, these are specific for eating disorders. So unlike a lot of psychiatric wards, they're a little bit more capable of doing refeeding and monitoring the medical issues that come up with people with eating disorders. So they would give them a prescribed activity level, which usually initially is nothing, definitely for the anorexics at least. They would do close monitoring of vital signs and weight. They would be having a very specific diet that they have to follow with strict I's and O's. Examples of restrictions would be no outside food, so that you can have the strict I's and O's. No food be left in the room after the meal is completed. No cafeteria privileges for meals or snacks. No bathroom use for at least 1 hour after meals, so they can't engage in compensatory behaviors. And like for the first 24 hours, you might only have immediate family allowed to visit, and they may leave the unit unless it's deemed appropriate by the care team for them to be able to go out and wander around, because they may engage in behaviors, or if they're a bulimic patient, find food someplace and eat it. So those are just some of the kinds of things. Like if you have a patient that you're sending to inpatient, have some awareness so that you can explain to them what they might see if they end up going to an inpatient ward. Next slide, please.
And so now we're going to explore some behavioral health interventions, and Dr. Clark will walk us through some evidence-based treatment from the behavioral health perspective.
Good afternoon, everyone. It's definitely a pleasure to be here to speak from the behavioral perspective on eating disorders. So one of the easiest ways to kind of do that initial screen is just to simply ask the question, how many meals do you eat a day during, your encounters with the patients day to day. From there, depending on, what you gather from that assessment, there are quick screening tools for eating disorders. The SCOFF, which is the Sick Control Over Fat Food, is a quick 5-question questionnaire screening tool, which awards 1 point per answer. So any answer 2 or more requires follow-up care, or at least a more detailed screening tool to be used to rule out any eating disorders. The eating disorder screening for primary care is another quick tool. It's a 5-question. I know it's the same thing, 1 point per answer, and anything over 2 will require follow-up care or a more in-depth screening tool to be utilized to rule out an eating disorder. Next slide. So the longer screening tools, the eating disorder examination questionnaire, the EDEQ, is the gold standard. It's the 28 questions, so it's a little more in depth and definitely a good resource to utilize in determining whether or not a patient has an eating disorder. There's also the eating attitudes test, the BED, which is the bulimia eating, the binge eating disorder, screening tool, and the female athlete screening tool, and the compulsive exercise test that can be utilized as more in depth in determining the grounds for the diagnosis of an eating disorder. Okay, next slide. The evidence-based therapies utilized for eating disorders in treatment and in therapy are one of the major ones is the cognitive behavioral therapy and the enhanced cognitive behavioral therapy. What CBT does is it absolutely identifies challenges and implements new thoughts and behaviors, helps the patient focus on changing the thoughts and the patterns and the beliefs that contribute to the eating disorder. So it's definitely significant when it comes to learning new strategies and implementing lifelong sustained changes. Interpersonal psychotherapy, definitely getting to the root of the cause of the eating disorders. Based on studies, it's shown that about 94% of eating disorders definitely have a co-occurring diagnosis of depression, anxiety, PTSD, and some underlying, unaddressed, untreated trauma. Next slide, please. So when it comes to the family-based treatment and evidence-based therapies, definitely a high priority when treating children and adolescents. The failure rate in children and adolescents is significantly higher than it is for adults, just simply due to, you can teach the child new skills, new strategies. However, if the family environment and the family unit isn't in support of or supportive to these new changes, then the failure rate is absolutely significantly higher. And they tend to have more of a lifelong struggle with, going in and out of treatments and unresolved eating disorders. CPS, Child Protective Services, at a higher rate has to get involved with those instances as well. So that's definitely something to consider. Dialectical behavioral therapy focuses on managing difficult emotions. So what we've learned from eating disorders and one's ability or inability to manage their emotions or regulate emotionally, DBT focuses on that, and it definitely addresses the interpersonal perspective. It incorporates a mindfulness approach. So, being intentional and being mindful of the behaviors of your thoughts and the managing of emotions, which is significant in treating it. Eating disorders. All right, next slide. So the prognosis for improvement, I'll give you the opportunity to take a look at some of these. And looking at these are for adults. So when you think about children, it is significantly lower, the percentages of good outcomes, intermediate outcomes, and their poor outcomes. When it comes to military, I guess an example of a good outcome would be managed and or sustained recovery. So able to, sustain the skills, the healthy skills and strategies that they've learned through treatment and therapy. More of the intermediate would be use of aftercare services, high uses of the support groups and or resources to manage and support their recovery. A poor outcome for military would be a condition or eating disorder that is med boardable or death. It's definitely something to look at. Let's see. Next slide, please. So some of the local treatment resources that are in network, these are a couple that we have listed. I will definitely say there's a significantly difference in available services on the East Coast than on the West Coast. So when considering care for a patient, looking at the closest facilities or closer facilities shouldn't be the only option that is considered, because what TRICARE has understood, and from my conversations with TRICARE representatives, is that wherever a facility is that is willing to accept TRICARE Prime, then they definitely will cover those services. So it doesn't have to necessarily be in the local area. However, the ones that we do have in the local area, the Prosperity Eating Disorders and Wellness Program, they offer the virtual IOP, so intensive outpatient for adults. And they also have the in-person as well. With COVID, things have really kind of changed. So a lot of them were trying to get their virtual programs up and running. So it's definitely something to ask. You can always give them a call, and the contact numbers are included, or at least the website links are included for your convenience. Total Health Concepts was another intensive outpatient transitional program. Reflections Eating Disorder Treatment Center, located in Virginia. It had the inpatient services that are kind of rare in this area. Once a patient is considered stable, medically stable, then rolling into inpatient, they will typically, with eating disorders, be rotated or stepped down into another level of care. So that next program from inpatient would be the partial hospitalization. From the partial hospitalization, of course, the intensive outpatient and or outpatient programs. The Center for Discovery Eating Disorder Treatment is a good resource because they are offering the IOP and the PHP. And however, though they are listed in this area as it being in this area, they have facilities in 13 different states. So if TRICARE is accepted from this facility, then the other 13 different facilities, the services will be offered as well. It definitely would take a phone call to determine which services are covered in the different states, because they were in the process of ensuring that all 13 facilities offered IOP and PHP through TRICARE, from a TRICARE approved perspective. Next slide. Local out of network resources: Oliver Pyatt Center, the Body Image Center, and the Eating Recovery Center. So these are some sources that aren't on the network, However, they are in the general vicinity of Bethesda, Walter Reed. Another thing to consider is waitlisting. On average, each facility has a wait list of about 4 to 6 weeks. So with the 4 to 6 week wait list, there are other things that can be considered. Next slide. Which are the supportive resources, which rolls us right into it. So when speaking with TRICARE, you can direct the patient online to find a therapist that specializes in eating disorders. Doesn't necessarily, while they're waiting, have to be a facility that offers the care. So being able to at least get a jump start on the treatment of the eating disorder would be imperative for their recovery. So, you know, finding the different support groups, finding the different therapists in the area that offer eating specified or that specialize in eating disorders is imperative to, one, preparing them for this process and this journey into treating their and going through treatment process of treating eating disorders. The Overeaters Anonymous, they offer virtual, in-person, and by phone support groups and meetings, and they are held locally and nationally, internationally. So if you have someone that is in a different country, they can absolutely go to the website and find resources that are close to them, or they can log in from international other countries. Next slide, please. Questions?
All right, thank you for that great presentation. So if anybody has any questions, please go ahead and put it in the chat, or feel free to unmute yourself and speak, and you can ask the question directly. I have one question. I guess this question is for Dr. Schneider. In terms of the olanzapine for anorexia, is it just for weight gain, or does it treat the underlying kind of behavior?
Yeah, that was basically for weight gain.
So it seems like there is no medication that we would use for kind of the behavior, the underlying behavior.
Yeah, nothing that has been shown to date to be that effective, specifically for the behaviors that they have, unless they're using a lot of binging as well, which can be, but isn't always as frequent as with the binge eating or the bulimia. But if that is their preferred way of compensating, I mean, they usually are more restrictive in exercise and that kind of thing, but it may be true. So. But it does not help with those distortions, even though it's an antipsychotic, as I was saying before. But like I said, I've never had a patient not gain weight on olanzapine. Never.
And so when you think about your role in managing it, at least at USU, the counseling center can kind of be the first belly button to push in terms of getting the resources and information that you may need. We do manage some eating disorders on an outpatient basis, but as you can see, most of them are significantly complicated, which often exceeds our level of care at the counseling center. But we can be of assistance in ensuring that you find the right resource to plug the patient into. What we're going to do is we're going to put out a handout, and I'll make sure that it's available to everyone who joined. We'll send a follow-up email, as well as make sure that it's available at the clinic. And the handout will kind of capture some of these sources that we talked about with their websites and their information, just so you can have it handy if you have questions from folks that come in and see you who are contemplating treatment. Sometimes providing them information about what they can expect will be a good bridge to move them from that denial and apprehension into receiving care.
Colonel Keller, there are some questions in the chat. Are you able to see the chat? Or I can read the question out.
And for Angela, yes, we definitely will be able to provide the slides as well. And for Mike, he asked about using the initial diagnosis of RED-S, the relative energy deficiency in sport, for folks who are, that's like as far as I can read. And I'll let Brett kind of answer that question in terms of a relative energy deficiency in sport as a diagnosis.
I guess, Mike, I guess you're probably talking about mostly the eating disorder NOS, or are you talking about the full spectrum of people? If it's the eating disorder NOS kind of person or unspecified, I completely agree with that. I wasn't even necessarily familiar with that particular diagnosis, but I like it. But I think for the other diagnoses, other than maybe even for binge eating disorder, you could get away with that a little bit. But definitely for bulimia or anorexia, I would still think that we need to document them appropriately upon confirmation that we believe that that's the actual diagnosis, because the fact is that you'll need that diagnosis to get them into some of these other levels of care if they're going to be needing them.
And Emily had a question in regards to the new NDAA about eating disorder treatment and how this new law can change treatment accessibility. And I think Nikhil will be able to answer that, Dr. Clark.
So as far as the NDAA and the provisions about eating disorder treatment, what TRICARE is working on is trying to increase the availability of treatment in the local areas, which there have been significant changes on the West Coast. They're still working on the East Coast as far as trying to identify facilities, because there is a lot that goes into that. And with that, they have upped their available option for eating disorder specific therapists to kind of help, fill in the blanks with that some. So there has been an increase in available treatment options. However, it's not where it should be typically, where everyone would like it to be, I would say, based on the NDAA provisions that were implemented with that.
And so I think we're moving in the right direction as a military, because there has been some significant changes even within the culture. And so we're taking away the DA photos as part of the promotion board. We are offering more healthy choices within our dining facilities and even in our deployed environments. We are increasing our authorizations for dietitians and nutritionists within our healthcare system. We are taking a more wellness-focused approach, mind, body, and what we put in our body. And so as these changes kind of continue, it's directly pointed at trying to improve a more positive relationship with food. And even the restrictions when we're not passing height and weight and APFTs, it affects some things professionally, but service members are allowed to take leave, so it doesn't interfere with some of those things to kind of de-stress and provide us comfort around improving those particular areas. So there is a shift, but like in any cultural change, you want to look at it as turning a battleship versus or aircraft carrier versus turning a speedboat. You know, when you turn an aircraft carrier, you have to start to plan that turn 3 or 4 miles ahead of time, and then it's a nice, slow, gradual turn versus a speedboat that you can kind of whip in and out of the waves. And so that was an Army person doing their best to use a Navy analogy. So Mike, hopefully I didn't mess that up too bad.
Looks like we don't have any more questions in the chat. Unless anybody has any other questions to ask, or if Colonel Keller, Dr. Schneider, or Dr. Clark don't have anything else to add, we will end here. I put in links to do the session evaluations as well as a survey for the overall grand round. So please, if you haven't done so, complete those. And I would like to thank our speakers today. And our next grand round is going to be on February 9th. So I'll send out information about that. And I'll also send out handout from today when I receive it from Colonel Keller. With that, I'll say thank you and have a great rest of your week, everyone.